Hello and welcome. I'm Dr. Bob Arnott, and I have the pleasure of hosting a very important discussion surrounding a growing health epidemic, atrial fibrillation, or AF. This is a very personal topic for me, as my own father had AF and passed away from complications related to this disease. AF affects over 33 million people globally, and right here in the United States, 5 million. The symptoms can be quite debilitating, and the impact is enormous on the healthcare system. Today, I'm very fortunate to be joined by two experts on AF to share their expertise on their current treatment options to address this disease and discuss how to optimize outcomes. Dr. Suneet Mittal and Dr. Kedar Sankolkar. Dr. Mittal is the director of the Electrophysiology Laboratory and Associate Director of Cardiovascular Services for the Valley Health System. And Dr. Sankolkar is an attending cardiologist in Manhattan and is also with the Valley Health System. Now, they worked very closely over the last 3 years in identifying AF populations in their own practices and are here to discuss why and how they jointly manage these patients. Suneet, Kedar, welcome, and thank you so much for sharing your insights into addressing the growing challenge in atrial fibrillation.
Glad to be here, Bob.
Thanks, Bob. Happy to be here.
Great to have you here. Today we'll cover drug therapy. Now, do you use rate or rhythm control? What are the side effects of the rate and rhythm control drugs? Now, what's the overall prevalence of AF and who should be treated? What about drug therapy versus catheter ablation of AF? And should it be a single shot cryoballoon versus a point-by-point radiofrequency? And probably most important, what's the case for earlier ablation? Now, I want to start a discussion by taking a look at the background of AF treatment from the perspective of the cardiologist. I understand there are a number of potential benefits for patients who receive catheter ablation over drug therapy. Kedar, can you start this discussion by giving us a quick background on drug treatment, which is we all learned in medical school?
Sure, Bob. There are many drugs to treat AF, falling under two broad categories: AV nodal blocking agents and antiarrhythmic drugs. In 2002, we all know that there was the a-fib trial where the primary debate was focused on rate versus rhythm control with drugs for the treatment of AF. The overall conclusion of this trial was that there was no difference in survival between the two groups. In fact, there appeared to be a potential lower risk of adverse drug effects with the rate control strategy.
So, Suneet, is this something you can apply to all your patients?
Yeah, Bob, I think it's important to recognize that there was a secondary analysis from a-fib, which actually demonstrated the presence of sinus rhythm was associated with a 50% lower risk of death. However, the use of antiarrhythmic drugs to achieve sinus rhythm was associated with a 50% increased risk of death. Therefore, these results suggest to me that if a more effective method for maintaining sinus rhythm with fewer adverse effects were available, it might actually improve patient outcomes.
Wow. Despite drug therapy, disease management of atrial fibrillation remains a significant challenge, as reflected by the high disease burden and poor treatment outcomes. In order to effectively treat these patients, we need to improve suboptimal therapeutic outcomes. In the United States, there are an estimated 5 million patients with atrial fibrillation and approximately 1.5 million that are symptomatic and have failed at least one drug. Yet annually, only 10% of these indicated patients go on to receive catheter ablation to treat their AF. There remains a large opportunity to potentially impact more AF patient lives each year. Suneet and Kedar, please share your thoughts on the prevalence of AF and the opportunity to treat more patients.
Yeah, Bob, from my perspective as an electrophysiologist, I agree completely that there is an opportunity to effectively treat more patients and earlier with catheter ablation. That is why a partnership with our cardiology group helps us put the AF patient at the forefront of receiving the most optimal treatment, which for many patients is catheter ablation.
Right, and in my experience, if a patient fails one drug, they often fail more. And that's when I send them to you, Suneet, much earlier than I've done in the past. What previously prevented me from referring for catheter ablation were a number of misconceptions. What I saw some years ago was that ablation procedures seemed long, complicated, and didn't always seem to be effective.
Let's take a look at the guidelines as they relate to catheter ablation.
Sure. Over time, the guidelines have evolved, recognizing the growing body of evidence in favor of catheter ablation. In 2006, ablation was considered only an alternative treatment. By 2011, catheter ablation was regarded as a useful tool, but in highly experienced centers. The most recent 2014 guidelines recognize catheter ablation as an effective tool for the treatment of patients with drug-refractory paroxysmal atrial fibrillation.
Terrific. Now, Catheter, let's talk about catheter ablation and what it's all about.
Yeah. In the past, many cardiologists thought of AF ablation as this extensive surgical procedure requiring multiple lesions in the left atrium. However, in the past decade, the literature suggests that the primary triggers for AF are actually the pulmonary veins.
Wow.
Yeah, in fact, the consensus statement on catheter ablation recognizes pulmonary vein isolation as the cornerstone for all AF ablation procedures. And now, fortunately, we have far less invasive ways of achieving pulmonary vein isolation. In fact, to date, 5 randomized trials have been published demonstrating that there are actually no benefits of additional ablative lesions beyond the pulmonary veins.
And in the United States, the 2 most common ablation modalities approved for paroxysmal AF are, number 1, balloon catheter that uses very cold energy to create lesions, and number 2, a point-by-point focal catheter that uses heat to create lesions. Let's take a closer look at these 2 options. Now, Sunit, as operator of these ablation technologies, tell me about the 2 options and what you're trying to accomplish with the procedure. And of course, you do both, so you know them well.
Of course. Well, Bob, the goal of catheter ablation, irrespective of whether it's cryoballoon or radiofrequency energy, is to create a circle of scar where the pulmonary veins meet the left atrium. Now, this prevents the abnormal electrical firing from these veins from initiating atrial fibrillation. Now, the cryoballoon, as shown on the left, was anatomically designed to isolate the pulmonary veins through a single-shot application of cryoenergy to create a contiguous circumferential ablative lesions. In contrast, radiofrequency ablation, shown on the right, uses a focal catheter to obtain pulmonary vein isolation by connecting these lesions in a point-to-point series of applications to draw a circle around the pulmonary veins.
So when you contrast these 2 techniques, you have to laboriously make this circle with a point-by-point RF, where you can do this all at once with cryoballoon. Catheter, how do you talk to your patients about these choices in catheter ablation?
Bob, simply, I tell them that it's a minimally invasive procedure. It has a high efficacy, especially when compared to drugs, and the complication rate is really relatively low.
We have discussed the evolution into the current guidelines. Let's discuss some of the evidence that drove these decisions to place catheter ablation so favorably. Sunit?
Yeah, Bob, we now have multiple randomized studies demonstrating through direct comparison that catheter ablation is superior to antiarrhythmic drugs in the treatment of paroxysmal atrial fibrillation. Now, shown here are the results of 2 separate clinical trials. On the left, the trial for the first-generation cryoballoon, and on the right, the trial for the Thermocool open irrigated RF catheter. Both trials demonstrated that catheter ablation is significantly more effective than antiarrhythmic drugs in patients with symptomatic paroxysmal atrial fibrillation.
Very convincing. In this growing AF population, we've established that catheter ablation is superior to drug therapy. Yet many are left untreated, as many as 90% of indicating patients, which must be pretty frustrating to you. In the U.S., 2 treatment modalities for catheter ablation are currently approved. What about the different energy sources for the pulmonary vein? It is hot versus cold. Now, Sunit, as an electrophysiologist that offers both of these technologies to your patients, how do they compare?
Sure. But that's a great question. And the Fire and Ice trial gave us a large and robust data set that finally helped us answer your particular question. For the first time, we were able to definitively prove that from a clinical trial perspective, that cryoablation was non-inferior to radiofrequency ablation. Now, this trial had a very strict definition of failure, which included time to first recurrence of any atrial arrhythmia lasting more than 30 seconds, the need for repeat ablation, or prescription of an antiarrhythmic drug beyond the 90-day blanking period post-ablation. Now, by this very strict definition, 2/3 of patients remained in sinus rhythm following ablation.
Now, Sunit, I appreciate that the definition of failure was very strict, but I'm a little curious about the percentage of patients free from recurrence being in the 60 to 70% range. Is that, in your opinion, enough for cardiologists to encourage their patients to consider ablation?
Catheter, that's a great question. I'm going to use this visual to address your concern. Now here, each blue line represents an AF recurrence of varying duration. In a clinical trial setting, typically the definitions of success are very strict, as we just mentioned. So only the patient shown on top is considered a success, because if a patient has even one recurrence of atrial fibrillation during the trial period, they're considered a failure. Therefore, the patient with an isolated recurrence and the patient with frequent recurrences would both be considered failures of the ablation procedure. However, in practice, we would consider our patient with only an isolated recurrence of atrial fibrillation to also have achieved clinical success.
You know, if I send you a patient that has weekly or even monthly symptoms of AF, and after AF catheter ablation, they have only a single episode over the entire next year, they would be considered a failure, I guess, from a clinical trial perspective. But you're right, in the eyes of the patient, in the eyes of me and my cardiologists that I work with, there's still a success clinically because the symptom burden is much less.
So we've discussed that cryoablation was non-inferior to radiofrequency, which was previously considered the gold standard. And this is in a rigorous clinical trial setting. What evidence is there showing differences from an overall patient outcomes perspective? Sunit?
Well, Bob, keeping in mind the differences between clinical trial success and clinical practice success demonstrating reduced patient burden, let's take a closer look at the results of the Fire and Ice study in a more real-world application. Now, this additional analysis focused on the true patient experiences by not looking at only the very first failure, but by looking at each patient's total experience. This included every hospitalization and repeat ablation after the initial catheter ablation procedure. These analyses demonstrated that patients had very different experiences depending on the treatment arm. The cryoballoon patients had 34% fewer cardiovascular hospitalizations and 33% fewer repeat ablations compared to the patients treated with radiofrequency energy in this trial. Now, the obvious question is why? And so on the next slide, we will look at lesion durability. Now, the ability to achieve durable and transmural lesions is key for a successful ablation procedure. The cryoballoon has demonstrated the ability to achieve very high rates of durable pulmonary vein isolation, which I believe likely explains this observed clinical benefit.
So this may help explain why there are better patient outcomes with cryoballoon. Sunit, how reproducible are these results with cryoballoon?
Yeah, well, Bob, very important question. And with the continued emphasis on the importance of predictability of outcomes, we look at this multi-center analysis. Now, the cryoballoon demonstrated greater reproducibility of patient outcomes and procedure times compared to radiofrequency energy amongst hospitals with varying experience and procedural volume. Now, this could be very important for hospital systems responsible for delivering consistent outcomes across populations of patients.
So Sunit, the efficacy and durability for the cryoballoon are well established, but safety is equally important. Do you find cryoballoon as safe as RF ablation?
Yeah, Catheter, let's talk a little bit about how safe catheter ablation is in general. A large meta-analysis demonstrated that the overall incidence of adverse events was low, irrespective of whether patients underwent cryoballoon or radiofrequency-based ablation. As an example, stroke was exceedingly rare with both. the need to proceed to emergent open heart surgery to manage acute complications was not observed. Frankly, I can't remember the last time we had to send a patient to emergent open heart surgery to manage an acute procedural complication. Next, pericardial tamponade was significantly lower in the cryoballoon group. Now, on the other hand, the incidence of phrenic nerve injury was higher. However, it was exceedingly rare for this injury to persist beyond 12 months. Now, the overall incidence of event rates for AF ablation is almost comparable to what we observe with other forms of SVT ablation.
So at this stage, we've discussed the benefits of catheter ablation versus drugs and the benefits of cryoballoon over point-by-point RF ablation. What else is important to know, Sunit? That is, what do you share about slowing the actual progression of this disease, which is thought to be a progressive disease?
Absolutely, Bob. As you mentioned, AF as a disease continues to progress. And if you treat it earlier, you can slow or stop this progression. Now, this is one study that aims to prove this point. In this study, patients were ablated, and the investigators saw what their progression of atrial fibrillation was. And what they found was when they compared this to a matched cohort of patients with atrial fibrillation who were treated with drugs, the patients who underwent ablation had a lower rate of AF progression compared to drug therapy alone. Furthermore, if we look at another study and you compared patients who underwent catheter ablation versus those who were treated medically, these investigators found that catheter ablation was associated with a lower risk of stroke and a lower risk of mortality compared to patients treated medically. And finally, on the next slide, we look at outcomes as it relates to the length of time from the initial AF diagnosis until the ablation procedure occurred. Simply, patients do better the earlier they're treated. This large study evaluated the impact of earlier treatment of AF by catheter ablation and found that delays in treatment impacted adversely long-term clinical success as defined by important endpoints like heart failure and death. The earlier we can treat these patients, Bob, these patients who are indicated for catheter ablation, the better expectations we can have for their long-term success.
So, Sunit, these are compelling reasons to treat AF earlier in the care continuum. Catheter, how do you explain these benefits of catheter ablation to your patients, especially if they're early in the disease?
Yeah, that's a great question, Bob. I tell my patients that compared to daily medication use for a lifetime, it's a one-shot approach with the hopes of making a real difference in their quality of life. You'll worry less about canceling trips or leaving early from events due to debilitating episodes of AF. With paroxysmal atrial fibrillation, you just never know when it's going to get the best of you.
Today, we've discussed a number of potential benefits to indicated patients receiving catheter ablation, specifically safety and effectiveness compared to drugs, improved outcomes, and reduced AF symptom burden. There also appears to be a number of benefits in these patients being treated earlier in the disease paradigm, as improved outcomes have been demonstrated through earlier treatment. Finally, cryoballoon catheter ablation appears to have a number of benefits over radiofrequency treatment in terms of fewer repeat ablations, fewer cardiovascular hospitalizations, as well as significant differences in terms of consistent and reproducible results. We certainly have a tremendous opportunity to bring the benefits of catheter ablation to more indicated patients and potentially refer them earlier to improve outcomes and reduce disease progression. I want to thank you all for your attention today. We're now going to transition to questions and answers. So now, Sunit, you're at Valley Health, spectacular facility that I visited. I mean, one of the most state-of-the-art facilities I've seen any place. What enables you to treat so many patients efficiently? What are you doing differently that other practices can learn about how you apply this to your own practice and your wonderful cooperation with Catheter?
Yeah, Bob, I think the key begins with the fact that we have a collaborative approach. And together, I think we've come to recognize that a lot of patients in our practice have atrial fibrillation. Many are very symptomatic from atrial fibrillation. And for many, a drug does quite a good job of controlling their symptoms. But what we've come to recognize for many, unfortunately, drug therapy simply is not enough to control their symptoms. And that's where Catheter and I have now come to recognize and have shared this with our colleagues, that at that point, the patient deserves a discussion to determine whether a procedure like catheter ablation may be the right procedure early in the disease process to help manage their condition and achieve the best long-term outcomes.
Yep.
And that's what's great too about the fact that you teamed up. You have a cardiologist, an electrophysiologist. You can both push back a little bit and figure out what's best for the patient.
Correct.
You know?
Absolutely.
Now, Sunit, want to get a little bit down into the weeds here. How long is this cryoballoon procedure? How's the recovery? And do patients have any pain or discomfort before, during, or after?
Yeah, Bob, in general, what we tell our patients is the procedure will be done under some form of anesthesia, so patients are typically quite comfortable during the procedure. These days, the total procedure time is about 3 hours, and our patients spend the night in the hospital and are discharged to home early the next day. We tell our patients that they can expect a minor degree of discomfort in the groins where catheters are introduced, and possibly in the chest due to the effect of the ablation procedure. Typically within 48 to 72 hours, these adverse symptoms have resolved, and certainly a few days after that, patients have returned to full physical activity.
That's great. So, Catheter, here's a great question. That is, look, you have a lot of AF patients, and they could have a lot of sort of other risk factors. They could have sleep apnea, they could be obese, they could be hypertensive, lots of different kinds of things. Do you deal with that first? Do you deal with those risk factors first? And sort of what happens to atrial fibrillation? And do you want to sort of modify all those risk factors before you call Sunit up and say, let's talk about this patient?
Yeah, Bob, that's a fantastic and super important question, near and dear to my heart. That's kind of the bread and butter of what I need to do in my practice. A-fib happens for a multitude of reasons, and controlling and addressing those risk factors sooner rather than later is very important, and then working with them through the entire process, even after I refer to Sunit, is very important. It helps with prepping them for the actual AF ablation, and then ensuring success after the ablation.
And Bob, if I may add to that, yeah, I think this is a very important question you raised, Bob, because although we're talking today about catheter ablation, it's important to note that we're doctors first and ablation is second. Right. And so when I see a patient with atrial fibrillation, and Catheter and I, we speak about, hey, why did this patient develop atrial fibrillation in the first place? And there are certain things that we have to be very cognizant of addressing. Is it a weight issue? Is there something that we can do by helping a patient understand their eating patterns? Is it a lifestyle issue? Are they stressed out? Could they benefit from interventions like yoga? Is it an issue where sleep apnea has been unaddressed and needs to be addressed? Can we help them on an exercise regimen where they can lose weight? Is the blood pressure or diabetes not well controlled? Unless we pay attention to these and control these well, catheter ablation will not be effective in achieving a final good outcome. So we have to look at the total patient.
May not be as good.
Absolutely, absolutely. So we have to look at the whole patient, work together.
Yep.
And then use catheter ablation as an important modality, but not the only modality to achieving the best long-term outcomes.
So now, Catheter, your reputation's on the line. You recommend this procedure. You refer the patient to Sunit. You like that it's just one shot, sort of one and done. A great question we have here from a cardiologist, and that is, how many of these cryoballoon procedures are typically needed?
Now, I'm a little lucky when you say my reputation's on the line, because when you work with Dr. Mittal, I really have nothing to worry about.
Fantastic. I'm
but
sure that's
in all honesty, in my own practice, anecdotally, the patients come back requiring no further procedures, at the most 1, maybe 2, and I don't remember the last time I saw that.
Yeah, Bob, I think that, again, that goes to what you mentioned before about risk factor modification. Our job is to ensure that the patient achieves the maximal benefit with a single procedure. And if we can control the risk factors, modify the things that need to be modified, and do those in a way where we use the ablation procedure and then continue to focus on things, we're confident in the majority of our patients, only a single procedure will ever be necessary.
So now the $1 million question, Sydney, from a patient's perspective, is going to be, can I get off the anticoagulants, right? And you'd figure, you do the procedure, it's successful, there are no many more episodes there. One would assume you could get off, but...
Well, Bob, it's at least the $64,000 question,
Okay.
I would say.
It's worth that much.
So, this is a very important question. And, the classic teaching today is that if you had risk factors for stroke prior to the catheter ablation procedure, those risk factors haven't gone away, so you've got to stay on anticoagulation afterwards. Now, you can imagine from the standpoint of a patient, the patient asks, look, if I didn't have atrial fibrillation, you wouldn't be putting me on anticoagulation. If you have treated my atrial fibrillation, why do I need to stay on anticoagulation? A very reasonable question. There is a tremendous amount of investigation currently underway in electrophysiology to help get an answer to this question. And we're doing this by looking at simple strategies, like maybe having a patient check their pulse once or twice a day. Maybe some intermediate strategies, like using the smartphone today to look at your EKG and monitor your rhythm on a daily basis, to even more sophisticated technologies like having microchips inserted underneath the skin, which can give us continuous ECG data over a period of years to determine if one of these approaches can be used to determine which patients are at low risk of stroke, and that we can safely withdraw anticoagulation. And I hope, Bob, when we have this discussion again in a couple of years, that I'll have a definitive answer for you.
It would be fantastic for patients, really would. So, Catheter, you're dealing with internists and general practitioners who've referred to you, and obviously you want to talk to them about risk factor modification, but how do you sort of sell them on, as an example, early ablative therapy?
Right. I mean, it's really easy because there's so much evidence backing this up. And I kind of consider myself the middleman between my EP guys and my referring base. As much of a collaboration I have with Suneeth, I have an equal and just as strong of a collaboration with my referring docs, whether they be internists, family medicine doctors, NPs, PAs. I pick up the phone call, I talk to them man to man, man to woman, just 3 to 5 minutes, educating them about what the best next steps are for their patients. And again, it's like what Suneeth said before, just be the doctor for that patient, whatever it requires. And it really takes a quick phone call where they understand why we're doing this.
And so what's the best way of dealing with these physicians, that is referring physicians, in terms of convincing them about the options for ablation?
Yeah, but Bob, I think one of the key things is to understand what the expectations of the procedure are and what we believe the patient can stand to benefit as the value proposition. And as we showed earlier today, of course, for many patients, all atrial fibrillation will go away. But there are a number of patients where they may continue to have atrial fibrillation, but the burden will be reduced to the point where it's a very tolerable disease. And I think it's important to set those expectations with the referring doctors in terms of what we're trying to achieve. The other important thing to recognize is that we have to allow people to understand that the ablation procedure is just one component of the patient's treatment, and we still have to be aggressive with all the things we talked about before, the risk factor modification, which is an important pillar that ultimately contributes to the long-term success or failure of these procedures.
And you're relying them to keep them on the anticoagulants.
Absolutely.
As well. So now here's a really interesting question. This one's for you, Suneeth, in terms of age. Really, it's sort of a twofold question. That is, late appearance atrial fibrillation, they're more likely to correlate. It's a disease that occurs as you sort of get older. If you get them early, are you likely to still get a pretty good result? And what about those patients, the older patients who've had this disease for decades? Do you still have a chance, still a shot?
Yeah, so Bob, I think that the age is an important variable. Of course, we know patients with atrial fibrillation will be older because a-fib is a disease that increases in prevalence with age. But age alone can't help us determine whether patients will or will not benefit from this procedure. I'll give you an example. Actually, just today, I saw a 73-year-old male who developed paroxysmal atrial fibrillation for the first time over just the past couple of months. Has no relevant past medical history, is lean, in excellent shape, very functional. This is the kind of patient, despite his age of 73 years, is likely to do very well with a catheter ablation procedure. On the other hand, I could have a 73-year-old male who has hypertension, diabetes, has congestive heart failure, renal dysfunction. that patient is not as likely to do well with an ablation procedure, especially as you said, the a-fib has been present for a decade.
Would you still give it, consider the patient?
Well, I think every patient, we have to make an individualized decision. We weigh the risks and benefits, and we engage in a shared decision-making with the patient where we have clear expectations, and then we decide what's the best intervention for this patient.
So, Cindy, you have done RF for years. You do cryoablation. What, in your opinion, is the reason why you tend to have so few or so many fewer repeat ablations with a cryo balloon?
Well, Bob, as I tried to show earlier, I think a lot of this has to do with the fact that the cryo balloon does an excellent job of creating durable pulmonary vein isolation.
Just through and through.
Yeah, and I think that durability of the pulmonary vein isolation is translating into the improved clinical outcomes that I mentioned.
Now, Catheter, so why do drugs fail? And why are you more likely to fail as the disease progresses? Which, of course, is the argument for early ablation. But, why is it they fail in the first place? And why, as time goes on, do they tend to fail more and more?
Right, that's like the $63,000 question. But,
$1,000 discount, okay.
It goes back to basic science. Antiarrhythmic drugs are also pro-arrhythmic, so they are very likely to also cause arrhythmias. Besides that, there's the adverse effect profiles that can be horrible and debilitating for the patients themselves. And of course, the longer a patient has a-fib and as it progresses, it certainly becomes more and more difficult, at least in my anecdotal experience, my practice, to actually convert them or even control their symptoms.
Now, are these mostly new ventricular arrhythmias, or can a pro-arrhythmic drug actually create atrial fibrillation?
Anything.
Wow. Wow. Jeez. Now, Sydney, do you manage cryo and RO patients differently in the post-procedure period? You keep them overnight and you observe them whatnot.
Yeah, no, Bob, for us, obviously there are differences between the two procedures and how we approach it, but the post-operative recovery and our management strategy is really unchanged with respect to the two procedures.
So, Sydney, here's a very interesting last question. What about patients who can't tolerate long procedures, 3 hours, or have renal issues? What do you do with them?
Yeah, so of course you have to be able to tolerate some degree of the procedure, and the question is, why can't a patient tolerate a long procedure? The two most common reasons are people have difficulty with the notion of lying flat for that long. That's relieved by the fact that we use anesthesia during the procedures, which allows them to get comfortable during the procedure. I believe this issue with renal dysfunction is being raised largely because in the cryoballoon procedure, one of the things we often have to do is do angiography, which uses dye, to look at the pulmonary veins to see if the balloon is occluding those pulmonary veins. Fortunately, there's a lot of alternatives to dye in these high-risk patients. We can use ultrasound, and ultrasound is a very effective modality of determining whether the veins are occluded or not. So there are lots of options to do this procedure in patients with renal dysfunction.
And for your congestive heart failure patients that have continual runs of AF, do they improve after the procedure?
Well, yeah, so there are some data from clinical trials, so small studies suggesting that in patients with atrial fibrillation and heart failure, that ablation of atrial fibrillation can help. As you know, a-fib and heart failure are the big chicken and the egg. They're co-linked. A-fib causes heart failure causes atrial fibrillation, and often by treating the atrial fibrillation, we can mitigate the heart failure.
So this has been a lively and engaging discussion. Sydney, Catheter, just love your final thoughts.
Well, Bob, I think for me, the main thing is to know is that Catheter and I, we see a lot of atrial fibrillation. There are a lot of patients who continue to suffer from atrial fibrillation despite attempts at medical drug therapy. Fortunately, catheter ablation has evolved to the point where we're now starting to see relatively high efficacy rates, relatively low complication rates, and I think we've gone to the point that we need to have the discussion about catheter ablation early in the disease process with patients so we can get the best long-term outcomes for these patients.
Catheter.
And Bob, thanks. When I was in medical school, day one, they teach you first do no harm. And the immediate thought that comes to mind is, oh, don't send for procedure, don't be a cowboy. But when you have this much high quality evidence behind a-fib ablation, my question is, are we doing harm by not referring patients earlier? And I know I've started to believe that that may be the case. So just be a doctor to your patient, really look at the evidence behind it, and get a good collaboration with both your referrers as well as your EP guys.
And I got to say, really, I love your passion, and I love the way you care about and for your patients. It's
Thank you.
It's
Thanks,
a real
Bob.
inspiration.